Welcome to the NeoFOCUS-UK Education Group webinar series.
Okay, so welcome everybody to the NeoFOCUS UK webinar today, the 4th of April 2025. I'm just waiting a couple of seconds to allow the participant to come in through the Zoom app and join us. I see there's already more than 30 people joining us today. Many more have registered in the past days, so I see the number keeps going up, which is fantastic. So while we wait to start, just a few ground rules. All of you that have joined us, you see you will be muted and your webcam is off. That's to make sure that there's no interruptions to the flow of the webinar, which will be recorded and will be uploaded on our NeoFOCUS UK website. The option for you is to interact with the speakers today through the Q&A session. You can add questions through the Q&A option, which is on the bottom of the screen for your Zoom screen. We will be picking up those questions at the end of the session. As you know, it's a 1 hour session between 2 and 3, so all the questions towards the end. At the end, we'll also share a QR code that will take you to the feedback page, so you can share some feedback about the session, which will help us improve the way that we share knowledge and share our learnings through the NeoFOCUS UK education group. So I see, there's more than 50 people on the line now, fantastic. So I think it's time to introduce our two speakers, Dr. Robin van der Lee and Professor Mauro Pittiruti. Robin, he is a neonatologist currently working in Nijmegen in the Netherlands. He has been working hard in the past years in neonatal medicine with a major focus in use of ultrasound in NICU and POCUS essentially, and has a keen interest in pediatric vascular access. He's a trainer on POCUS, he's a trainer for neonatal vascular access insertion, and he is part of the specially interested group on vascular access within the hemodynamic section of the ESPR, and is a board member of the NEVAT group. So with him today, he is Professor Mauro Pittiruti. He's a professor as a surgeon in the Catholic University Hospital in Rome, and is a coordinator of multi-professional vascular access teams that has inserted thousands of access in kids and babies in the past years. And he has been working hard in the field of the venous access for many years, and is co-founder of the Italian Society of Parenteral and Enteral Nutrition, as well as the Italian group of vascular access devices. And through then has developed collaboration with the Vocova Foundation, the World Conference of Vascular Access, and has become then one of the co-founder of the International Neonatal European Vascular Access team. So we are very lucky to have Dr. Robin van der Lee and Professor Mauro Pittiruti with us today. Myself, Anna and Mahmoud will do our best to moderate this session, and we hope that there will be a lot of learnings that we can share, and I'm sure there's going to be a very interesting session today. So we start with Robin. If you'd like to share your slides, and then we can take it from there.
Thank you, Anna, for the very kind introduction, and welcome to you all. Of course, I hope everybody. I hope my slide is visible, Anna.
Yeah, perfect.
All right. So I'm going to talk you briefly and in an overview about recent advances in neonatal, but also in general vascular access. I have nothing really to disclose other than that I am a point of care ultrasound enthusiast, like most of you that have joined this webinar. So I'm going to touch about ultrasound, of course. I'm going to tell you something about devices, insertion locations. It is necessary for all patients, and it will enable tunneling, but more about that later. Point of care ultrasound in general, which is very useful also in conjunction with vascular access. I'm going to talk about glue, I'm going to talk about fixation, and I'm also going to talk about a little bit about the border phenomena like planning of vascular access and procedural sedation and analgesia, but very shortly. So equipment is rapidly evolving, like you know probably better than I do. We still have these large machines on wheels, but more and more the ultrasound probes are becoming portable. And for vascular access, naturally, you need high-frequency linear probes. So there's a lot of literature out there. I'm not going to talk about that. You can find it more and more on PubMed that ultrasound is being used for neonatal and pediatric vascular access in increasing amounts and for an increasing number of indications. And we all know these indications. I mean, these really big babies can be really very, very challenging to get IV access to. But the same may happen also with the smallest babies. And you may need to resort to other techniques than the standard landmark techniques to provide especially durable vascular access. So ultrasound enables us to actually cannulate vessels that are part of the central venous vasculature, which means especially the subclavian and jugular part, and also the femoral introduction routes. And we know from work from Giovanni Barone that about the diameters of these vessels. They published their work in 2019, and this has a direct implication for what you are going to put into it, because you want to do it safely. And ultrasound actually helps us putting in vascular access in a safe way. You want to prevent central venous thrombosis, and for that you would ideally have a catheter to vein ratio, a diameter ratio of 1/3. So a 3 millimeter vessel, you can put in maximally a 3 French catheter. This is so ultrasound. We can visualize now vessels that previously were cannulated sometimes blindly. On the left, on the top left is the brachiocephalic vein. But we can also visualize easier now the femoral vein, which can be challenging to cannulate because it's usually very closely to the femoral artery, sometimes even right below it. On the left lower screen, it's not running, but this is the infraclavicular part of the axillary vein, and you can also use ultrasound to cannulate peripheral arteries for arterial access. So possibilities are endless, and with adequate ultrasound equipment, you can even cannulate, for instance, peripheral arteries of a diameter of 0.5 millimeters. So even the tiniest infants can benefit from this. And then you get things like this. Not too long ago, we started putting arterial catheters in this in the axillary artery, because it's actually you can cannulate it, and you can beforehand you can measure the diameter and see if you can cannulate it safely. It will enable you to put in, for instance, in the middle picture, a femoral catheter and tunnel it so the hub comes out just past the diaper area, but also you can cannulate the brachiocephalic vein, use a 3 French catheter, and fixate it with for instance, a Securicat. What you see also in this picture is a kind of complication you really well, sometimes you see it, which is called a medical adhesive related skin injury. Babies that are where the skin reacts to the adhesive dressings. It will help you prevent complications. So the brachiocephalic vein you see on the top screen side is impinged by an aortic arch. So yes, you may be able to cannulate it, but you may also say, okay, this may be a little bit too difficult. And in this case, this was a 600-gram baby. I cannulated the axillary vein which was much safer and could get the catheter in the right place. And on the right hand, you can actually see a sort of between brackets complication, because this is a fibroblastic sleeve, and you can see it very often, especially after central venous access, which is a sheath of endothelial and fibrous material, which is not the same as a thrombus. So ultrasound also helps you to differentiate between a real complication, a central vascular thrombus, and a natural co-occurring phenomenon like a fibroblastic sheath. The heart, so point of care ultrasound in general will help you also identify complications. And the picture on the left was a very serious thrombus inside the heart, for which the baby eventually needed cardiac surgery, and he ended up on ECMO. He survived, but this was a very serious complication of an umbilical venous line. And pericardial effusions, the picture on the right, still can happen after endocardial penetration, especially also of umbilical venous catheters. So another very important advancement in vascular access has been cyanoacrylate glue, or superglue. So we usually use butyl, isobutyl, or octyl esters, where the butyl products provide the strength, and the octyl products provide more the flexibility. You can see in this picture that the original superglues were more like the methyl and ethyl kind of superglues, but in medical science we use the butyl and the octyl cyanoacrylates. And for vascular access, we actually like to use a combination of around 80% to octyl cyanoacrylate and butyl cyanoacrylate. So why is this glue so important? Well, first of all, it helps you, of course, with the initial fixation of the catheter when it exits the skin. But it does more than that, because it acts like a sealant, and it has a very strong antibacterial activity, and it is very aspecific. It actually it causes an environment where it sucks cells dry of any of water, and especially for bacteria. And they tested it in this journal, and they found that most, if not all, bacteria are very are not capable of withstanding this. And so superglue actually, cyanoacrylate actually provides a very effective antibacterial barrier of the exit site for the vascular access device. So the stabilization of the catheter starts with the superglue, but earlier we always used stitches. We shouldn't do that anymore, because you actually make more holes, and more holes means more chances for bacteria to grow into the skin and cause infections. So what we use almost exclusively now are sutureless devices, either through anchorage, like you see the orange device on the right, the SecureCut, or the adhesive devices, and there are many. There are various forms of them, and in several sizes, and they actually provide quite secure securement, and you cover them with a transparent membrane dressing. I'm actually going quite quickly through my slides, so Maro has more time to talk you through the tip location. So one other thing which is more and more coming to the front now is we start to think about vascular access, because it used to be, and it's in many centers it still is, vascular access is the last thing people think about. They they think about diagnosis, they think about therapy, and then they think, oh yeah, the baby still needs an IV, so let's do it. But they don't think about the indication, what kind of medication or fluid are going through, what's the skin condition, what is does the baby still have blood vessels, etc., etc. So you can actually make a plan of that, and in a very early stage of the sickness of the baby, you can decide, okay, this baby we can treat with a peripheral, so a short peripheral cannula, or this baby needs more long-term therapy or a more vesicant fluid, so we should provide central venous vascular access. And then you have quite a few options. And one of the important part is procedural comfort measures, because every stick through the skin will impact the health of this baby, but also of a child or an adult, actually. So if you don't need to hurt the patients, you shouldn't do that. So this is part of the work we are doing with NEVAT. This is one of those diagrams where we have some propositions about how to give procedural sedation if there is an IV present, but also if there is not an IV present, which is not unusual. And you can actually now give a lot of medication also through the nose or in the mouth. And I think this is a very important thing. And this looks easier than it appears to be, because what I found is that many people, they say, yeah, we don't want to hurt the baby, but they're actually scared about providing procedural sedation, because they think, oh, maybe the baby will crash because of the procedural sedation. But it's actually more likely that the baby will get hurt because of too much pain or stress. So these advances actually expand vascular access options, and especially ultrasound is responsible for that. This is really, really, really important. It also enables us to put in catheters and to tunnel them. So nowadays we can reliably put in catheters that used to be put in by surgeons, but we can do it as clinicians at the bedside. And all these advances, they help in preventing complications. More than 90% of complications you can prevent with the appropriate insertion and fixation procedure. And so these advances will improve safety for the baby, but also for us as healthcare professional. And the same holds true for satisfaction. It will improve patient and especially parent satisfaction, but also the satisfaction of you as healthcare providers, because you are more capable and you take better care of your patients. Thank you for your attention.
That was a fantastic overview from Robin in terms of the advances in insertions of lines in babies. And as we said at the beginning of the session, all questions will be at the end, because then we can, for now, move smoothly towards the presentation from Prof. Mauro Pettirotti. So Mauro, if you'd like to try to share your screen, we can then start with your presentation. And in the meantime, can confirm we have more than 80 participants, and they're all free to start adding some question in the Q&A session. We can see your presentation nicely. Perfect.
Okay, thank you very much for this invitation. We'll do a very rapid overview of the tip navigation and tip location neonates today. And as you already know, tip navigation is the assessment of the correct direction of the catheter during the maneuver. It's always intraprocedural. It is inevitably by ultrasound, while tip location is the assessment of the correct final position of the tip of the central catheter, which theoretically should be either post-procedural or intraprocedural. But most guidelines today recommend that tip location should be intraprocedural. These are the guidelines of the Infusion Nursing Society of 2024. The general recommendation for all population is to use preferably intracavitary electrocardiography for tip location, but in neonates is strongly different, and it's recommended to use ultrasound for the reasons which I will explain in this brief talk. One thing is certain, that we should avoid X-ray for tip location as a method of tip location. We should avoid fluoroscopy, and we should avoid also post-procedure radiograph. The X-ray is relatively inaccurate. It may be deceiving, especially in neonates. For instance, if you look at this catheter, it's an umbilical catheter which apparently at the X-ray is in the proper position, but at ultrasound is inside the liver. This is another example of an umbilical catheters, which apparently is right at the beginning of the heart of the right atrium, but on ultrasound is clearly inside a portal vein. Also, fluoroscopy is not possible, is not feasible in neonatal intensive care unit, so the radiology is always post-procedural, and post-procedural, it means that there is a high risk of malposition. And because you have to go back to the patient and to correct the position of the catheter. And that's also a nuisance. And the ESPNIC, the European Society of Pediatric Neonatal Intensive Care, recommends a POCUS, particularly for catheter tip position in neonates and children, with a very strong agreement, also considering that X-ray, and this is very important in neonates, it's not harmless because there's always an exposure to ionizing radiation, which should be avoided. The problem is mainly the training. This is a document of PEDIVAN, the Pediatric Special Interest Group of the EVA from USA, of many years ago, which recommends to improve the training of a specialist in neonatology for the new technology of insertion and tip location. And there are several potential barriers, such as a lack of trained personnel, lack of equipment, but the main problem is training. The lack of trained personnel, it is the real gap that we should fill. And in order to do something useful for simplified training, the GAVCELT and GAVEPED have developed a protocol which helps to understand which are the key factors for a good ultrasound-based tip location. The ECOTIP protocol, so this nickname, is really part of a set of different protocols in newborns, in children and adults. We'll focus only on the newborn protocols. Also because if we go back to the Infusion Nursing Society guidelines, there is a clear indication to consider use of ultrasound, particularly in neonates, where ultrasound is very, very easy. And the ECOTIP protocol helps you to understand which probes you should use, which acoustic windows, and which are the specific protocols for tip navigation and tip location. This is the original paper, which was published 4 years ago. And this is the table, which includes the main central lines, which are adopted, used in neonates. For each central line, there is a specific recommendation about the probe, the windows, and the technique to achieve tip navigation and tip location. I will go very rapidly through 3 different types of catheter, which are the umbilical venous catheters, in which the tip navigation and the tip location almost are the same thing, the same action. And it's done by microconvex probe or small sectorial probes using always the subcostal longitudinal view, which is the view which allows us to visualize the umbilical vein, the ductus venosus, and the inferior vena cava and the right atrium. For the tip navigation, we use a small sectorial probe, preferably. The acoustic window is always the subcostal longitudinal view. And interestingly, the act itself of ultrasound-based tip navigation is very useful because with the probe, we can make a small compression at the critical moment where the catheter passes from the umbilical venous to the ductus venosus. And this is something which has always been known by neonatologists. Usually you press with your hand, but you can directly press with your probe and make the trajectory of the catheter that you see here in green, the proper one, avoiding the risk of going to the portal veins. And when you go to the final location of the tip, which usually should be the junction between the intravenous cava, the inferior vena cava and the right atrium, you can do it with the same window by looking at the catheter directly or indirectly. This is an image which shows you the catheter, which is still far. With the bubble test, we see that the bubbles come from the umbilical veins, so the catheter is still far. And this is another example of a catheter which can be directly visualized at the junction. And this is the same image, but with a bubble test, where we flush with saline. This is the bubble test. We flush with saline the catheter, and we visualize the tip of the catheter. So we have the possibility of a tip location by direct and indirect visualization. Also, dynamically, we can see the catheter entering the ductus venosus and entering the right atrium, as you see in this brief video. Of course, the training is an issue, and you should train not only to use ultrasound for this purpose, but also to use ultrasound afterwards to check every 24 hours or even more frequently if needed, that the tip location is still the same, because the umbilical venous catheter, of course, they move, they have inevitable migration. The training has been explored by a very good paper by Giovanni Barone again, trying to show that a minimal training could reduce dramatically the time of the number of ultrasound-based tip location, increase the number of ultrasound-based tip location, decreasing dramatically the use of chest X-ray, and also have a faster visualization with a minimal number of manipulation in the first 24 hours after insertion of umbilical catheters. And this is another paper showing the benefit of ultrasound. 1 year ago, the GAVAChat and GAVAPED prepared a protocol for the safe insertion of umbilical venous catheters, and it's not surprised that one of the points was the recommendation of have a real-time tip navigation and tip location by ultrasound, according to this protocol. Is there a space for intracavitary EKG for umbilical venous catheter? I would rather say no. There are very old studies. This is a study of 25 years ago from Italy. There are very old studies, and the comparison with chest X-ray and, of course, EKG cannot give the tip navigation. It does not give the great advantage of following the catheter through its trajectory to the right atrium. And this has been shown also in this paper, always by Barone, of last year, where we have this sort of consensus review with consensus about the different role of intracavitary EKG and ultrasound. You see that as regards the umbilical venous catheter, The intracavitary EKG is considered applicable but not recommended, while the ultrasound is applicable and highly recommended. The second catheter with the percutaneous cava catheters, in which we can use different acoustic windows. This is the ECHO-TIP protocol again. There are specific recommendations about the probe and for tip navigation and the probe for tip location. The probe for tip navigation usually is a linear probe. Very often the hockey stick probe will be more comfortable, and we follow the trajectory of the percutaneous cava catheters if it comes from the upper limbs, following the RAPIVA, which is the rapid peripheral vein assessment developed by Gaveshet. And when it comes to the central area, by following the RACIVA, the rapid central vein assessment, we can follow the catheter in its entrance in the brachiocephalic vein up to its entrance in the superior vena cava. This is the brachiocephalic vein, and this is how this is the image, the window that we see with the linear probe. And this is an example of a catheter which gone the wrong way. Here you see that there's a catheter entering in the right brachiocephalic vein and going to the left brachiocephalic vein instead that going downward to the superior cava. These are all things that you can follow by a proper use of ultrasound. And at last, when the catheter is at the junction of the superior cava right atrium, which is the target area, you can use different kind of windows. This is a window which allows to see the superior vena cava, the azygos vein, the right atrium, and you see the catheter getting closer to the right atrium. And also you can use other different windows. It depends on your training, but in neonates, the vision of the right atrium is very simple. And we should consider that we can use the direct visualization of the catheter, as you see in this image, or also the indirect visualization as we use with a bubble test. If the epicutaneous cava catheters comes from the femoral veins, it's even easier because with the subcostal view, we can actually follow the trajectory of the catheter from the last part of the inferior vena cava up to the right atrium. And even when it's in the subdiaphragmatic area, we can visualize the catheter inside the inferior vena cava with a transhepatic view. This is a transhepatic view, and you see below the liver the image of the catheter inside the vena cava below the liver. And if you have any doubt, you can do the bubble. There is a training issue, of course, and there are already many papers which focus on this issue, and the effectiveness of tip location has been shown by many papers, many of them from Europe. I would say most of them from Europe. So that when we really decided to make a protocol for the safe insertion of percutaneous cava catheters, nicknamed the SIEC protocol, we decided to insert as a recommendation at point 4, as you see in the slide, the intraprocedural assessment of tip navigation, tip location by ultrasound. Can we use intracavitary EKG for percutaneous cava catheters? There are some concern. There are very few studies, but there is some. These are 2 studies from China, from 2017. There is a very good study from Italy, and there's another very recent study from China. There are some concern regarding the type of percutaneous cava catheters, because sometimes the percutaneous cava catheters, if they are too small, may not ensure the enough conductivity of the inside the columnus line, which is inside the catheter, so to get a very good electric signal. So if we come back to this very important paper by Barone and other colleagues, you see that coming to percutaneous cava catheters, the intracavitary EKG is considered applicable but not recommended, and exclusively for percutaneous catheters from the lower limbs, while it is strongly applicable and recommended the ultrasound tip location. And last, we many important neonatologists, many neonatal intensive care units use today the ultrasound-guided central catheters, which are the so-called CICC, central inserted central catheter, or FICC, femoral inserted central catheters, which are inserted by real-time ultrasound. And for this, the tip location can be done, for at least for CICC, can be done both by ultrasound and by EKG. There is a specific part of the NeoFOCUS protocol which tells you which probe, which acoustic windows, which is the procedure for tip navigation and tip location of these catheters. These are examples of ultrasound-guided catheters, tunneled and secured with the subcutaneous anchorage and glue. As Robin has said, these are the things which are really make this catheter particularly long-lasting and protected from complication. The tip navigation starts with the vision of the needle and the vision of the guide wire and the trajectory of the catheter, which can be done in a CICC very easily with the same linear probe by which we puncture. And this is an example of a catheter which getting to the superior vena cava. With the femoral, we also tunnel femoral. We also use a subcutaneous anchorage and glue for femoral. The tip navigation and tip location protocol is slightly different. We can see the guide wire or the catheter, as you see in this image, getting through the external iliac vein. And then you can follow the catheter in inferior vena cava, in the subdiaphragmatic vena cava by using the transhepatic lateral view. And then you can actually see the entrance of the catheter by using a subcostal view. It may sound difficult, but at the moment that you have your protocol, the procedure becomes very simple, and it's just a question of training, which for this catheter may be a little longer than for umbilical catheter, but still it's really rewarding because it will assure a terrific success and intraprocedural tip location. This is an example of a bubble test done with the femoral inserted central line, which you see is at the junction within inferior vena cava. And even if you don't see very clear the catheter with the direct visualization, when you see the bubbles, you see where the bubbles come from, you identify the tip of the catheter. And there is a bundle for Gavachet, also for ultrasound-guided insertion, which is for both neonatal and pediatrics. And the number 4 recommendation is to use intraprocedural tip location. In this regard, we probably can use also intercavitary EKG. Intercavitary method is particularly simple for CICC because they usually are 3 French of diameter, which means 1 millimeter, which is quite good in terms of column of saline. So the signal is very strong. There are several papers in the literature, again from Barone, from Mastroianni and Capasso. If we go back to that paper by Barone about the review of tip navigation, tip location method, we see that for CICC, the intracavitary EKG is the only central catheter in neonates where the EKG is applicable and highly recommended. But though we still remember that also ultrasound is applicable and recommended. The problem is that probably intercavitary EKG requires minimal training, almost no training. On the contrary, the ultrasound requires training. Remember that if you do intracavitary EKG in neonates, there is no need of any special monitor. You can use a standard monitor of the neonatal intensive care unit, but you must use the correct cable. And the cable, you might have some problem with the neonatal intensive care unit because you might need an adapter to connect the cable. But the expense is minimal. A cable like this may cost €8, which is much less of what is an X-ray or whatever. And there are some recommendations, such as set the speed of the display at 50 millimeter per second so that you can see the tracer better. So intracavitary EKG basically is perfect in neonates for ultrasound guided CSAC, but is quite not recommended for all other central line. As a conclusion, if you want to get into the world of ultrasound-based tip navigation, tip location in neonates, you must take a look and study the NeoQ-tip protocol, because it's the best way to standardize this procedure and to facilitate training. And one thing that facilitates training also is that each one has its own probe. I live always with a probe in my hand, and all through my working day. And I think that the vascular access specialist, and in particular neonatologist, should always have its own probe. These are probes which are very, very inexpensive, very handy, and of course they are multi-transducer, so that you can use it as a convex, a sector, and linear, because as you understood, when you do the tip navigation, tip location, you might need different types of probes. So this is the conclusion. Vascular access expert today should live with ultrasound in their hands. There are all of these concepts are also in this book, which is the most recent book about vascular access in neonates, also in the ARIA video on my website. And thank you very much. If you want to take a scan of this QR code, you can have directly all my contacts. And if you want this presentation or other materials, such as the papers which are presented in this presentation, I will be happy to share with anyone. Thank you.
Thank you, Mauro. That was a fantastic presentation again on the close connection between FOCUS as part of one of the advances in improving the way we provide care to patients when talking about access. I see that there are a few questions in the chat. If you don't mind, though, I'm going to start with my question to Robin. It's just because your overview of the advances in neonatal vascular access was really detailed in terms of the different aspects, from identifying which vessel, which line, how to secure it. And it made me reflect on the depth at which the NEVAT group goes into understanding how we can best apply best practice in this field. And I know that the NEVAT group is working on the recommendations on these topics. So I was just wondering if you want to mention that aspect. I think it's really important.
It's a very good point, Anna. We are working on, we have put together 10 recommendations along with a guide, which are currently finished. And we are in the process of finding the right way to publish them, of course, in an open access way, so they can be distributed to anybody who is practicing neonatal care. And I think, like you say, those recommendations, they really go into depth about all aspects of neonatal vascular access.
Thank you. Memo, do you want to go through some of the questions as well?
Yeah, I mean, I was just following on that item and that point, Robin. We're actually planning to do our framework here in the UK for central lines insertion. So we'll be actually guided by your work already, so we don't need to reinvent the wheel. So we'll be really looking forward to all your recommendation when it comes out, and then we can integrate that in our framework. I've got a question about when you presented your talk, Robin. You said you can differentiate with ultrasound between catheter shear and thrombus. So could you just elaborate a little bit more about that, please?
Well, and I know Mauro is actually much more knowledgeable about these fibroblastic sleeves, but these sleeves are a natural phenomenon. So any vascular access device, it holds even true for peripheral IVs. Not too long ago, I got an image from one of our physician assistants. He made an ultrasound of a peripheral vessel, and he actually found a ring inside because it was a short access. And then so I could tell, no, this is really normal. This is fibroblasts and endothelial cells that try to cover the surface of any vascular access device, make a sheath, and this is a natural body reaction. There are no thrombi involved, and as far as we know, it has no or maybe negligible risk of infection, but and it usually degrades by itself because the body removes it. This is in contrast with a thrombus, which is an amorphic and a more heterogeneous, has a more heterogeneous ultrasound signature with opaque parts and more clear parts, and thrombi usually are more heterogeneous in form, and they carry the risk, of course, of bacterial infection and occlusion or disruption.
Great, thank you so much. We've got actually questions started to come in. So one of the questions asking about the portable ultrasound probes, like for example, the one we use for lung ultrasound, the microlinear. Would you recommend that for vascular access?
Well, the question is for me. The probe for vascular access is inevitably a probe which must be linear, but also convex, also sectorial. And in children, there are specific megahertz that should take into account and a specific footprint. For instance, this is appropriate for children, for neonates, because the footprint is 3 millimeter, and also it's very good because it is a range which mainly between 10 and 14 megahertz. But there are also very good probes, linear probes, which are 10 even to 18 megahertz. The more the megahertz, the more, of course, you are detailed visualization of the very superficial area. But at the same time, we use them also for as sectorial or convex. This, for instance, as a sectorial convex. So either you have a laptop ultrasound with at least 3 probes, and in our neonatal intensive care unit, we have a couple of this small sort of table or computer-like, laptop-like ultrasound, which have these 3 probes. And I would suggest one probe should be linear with 26, 25 millimeters of footprint, and possibly with a hockey stick. The second should be a small sectorial probe, a more small cardiological probe. And third must be a microconvex. With these 3, you can do everything in the field of vascular access. But if you try to put them in just one probe, you must have a wireless. Otherwise, you must be sure to have these 3 probes in your portfaro.
May I comment on that? I think you're exactly right, Maro. But more and more, we have 2 kind of ultrasound machines in our unit. One, and both have this hockey stick. But one is a cardiology machine, which only has sectorial probes. And the other one is a radiology machine, which has especially a microconvex. And it's interesting to see that also with the microconvex, especially if you use it in the abdominal setting, you can visualize also cardiac structures quite nicely. So if you are, your budget is limited, you probably will get by with a hockey stick and a
microconvex.
And a microconvex.
I completely agree. And I think that considering that these wireless probes are inexpensive, they can be very helpful when you insert the umbilical venous catheters, for instance, in the delivery room in an emergency situation, where you can't have the big machinery of the ultrasound. Also, most of our neonatologists in my unit, they keep this in their pocket because they may want to check that the location of the umbilical venous catheter is still correct, for instance, or that the epicutaneal cavity catheter has no secondary malposition. And if you think maybe it's malposition and you have to call for someone to bring the bigger apparatus, it's something. But if you think maybe there's malposition and you immediately look with your probe, it's different. It's faster. It's more user-friendly.
Fantastic, thank you. There's so many other questions that are coming through, and one other question from Sarah is essentially the concept that when you start using POCUS, then you actually realize there are more things that you didn't know about. For example, the fact that when you have a epicutaneal cava catheter inserted, either inserted from the arm or the leg, when the limb moves, then the catheter can move in and out a little bit. And we know that we try not to have the tip of the catheter inside the heart to avoid complications. But do you have, Sarah is asking, do you have any recommendation in regards of at which point, at which length, in which position do you secure the line, knowing that there will be anyway some movement?
That's interesting because in the era of the post-procedural X-ray, this is something that could not be assessed. Now we are in the situation where we can decide with surgical precision where the tip is, even if inevitably the different pressure of the abdomen, of the chest, and the movement of the limbs, etc., will inevitably be associated with a certain movement of the tip. What we do now in Italy, according to the recommendation of Gaveped, is to insert the tip, to put the tip of the epicutaneal cava catheters, which come from the upper limb, at the junction, exactly at the junction. We know that with the movement of the heart, with the breathing, there will be some movement up and down. But I think that it's impossible that the catheter has the tip in a point. It's a tip in an area. There is a safe area, not a safe point. As regard the old concept, avoid the heart, please remember that the majority of the damage to the extravascular damage and also the late hemopericardium were associated to perforation of the lower part of the superior vena cava, where the wall is much thinner than the right atrium. So the problem of the late hemopericardium is a problem of the excessive movement of the tip of the epicutaneal cava catheters. Interestingly, this does not happen with the thicker catheter placed by ultrasound. So I think that the junction is now the safe point, or if you prefer, the area which allows a little movement in below and above the junction is the safer. The same is for the epicutaneal catheters which come from the lower limb. If you try to stay outside of the atrium, there is another risk that you are too low below the diaphragm, and then there is the hepatic veins. And if the epicutaneal catheter gets an hepatic vein, it's a very bad, very, very risky because of thrombosis, of course.
Thank you.
There is another question about some kind of use of sedation and analgesia. And in your experiences, have you used ketamine for procedural analgesia? And what would you recommend?
I routinely use esketamine, so not ketamine, but esketamine for procedural sedation. But we always use this latter. So we first use non-pharmacological methods, positioning, swaddling, sucrose, etc. And especially for the really small babies, you usually get by, especially for placement of a neonatal PICC or an ECC. If you need to put in a CICC, so centrally inserted catheter using ultrasound, you will probably need to sedate the baby a little bit, but you don't need to intubate them. And usually, what I do is at the moment that I start the puncture, then I give them a 0.5 milligram per kilogram of esketamine, usually the respiratory frequency lowers a little bit because it's usually around 50 or 60. That's too high when you want to cannulate, especially the brachiocephalic vein. It lowers a little bit, but they keep on breathing, and then you can safely do the procedure. As the babies are more mature, especially term babies or term babies that are several weeks or even months and beyond, you will, if you need procedural sedation, you will need more milligram per kilogram. And you can use esketamine not just intravenously, but you can also use it intranasally. It takes a bit more time to work, so you usually may have to take 10 or 15 minutes before you have the full effect. And for the intravenous esketamine, it's generally safe, but you need to give it slowly, and especially not just the medication, but also the fluid flush behind it. Because I once experienced a nurse who dutifully gave the esketamine very slowly and then pushed the esketamine in with the fluid bolus, and then the baby got into an apnea. But usually, if you do it slowly, there is no risk of apnea, even with the really small babies.
Great, thank you, Robin. There is another question about how often do you screen for thrombus, or making sure that the position is staying the same without malpositioning or migration?
Well, for the umbilical venous catheters, we recommend to do it every day, or anytime there is a manipulation of the catheter, which may be associated with a dislocation or dislodgement of the catheter. Though we are trying to use glue, which Robin has mentioned, also to avoid the dislodgement, the external dislodgement of the umbilical venous catheter. The other aspect of the umbilical venous catheter, which is the migration, the internal migration. So even if the catheter is not dislodged externally, it might migrate internally because of variation of resistance of the abdomen. So another indication for checking where the tip is when there is a major variation in the chest volume or in abdomen volume. Such as, for instance, the baby has a very, very big belly and there's some sort of gas or some sort of abdominal emergency, which has a distension of the abdomen. This is, for instance, for the epicondral catheters, you can do it every 48 hours. Unless there is, again, manipulation of the external part of the catheter or other events such as increase of the chest pressure, such as during ventilation or cough, etc., which may have moved the catheter. But it's really not a big problem anymore, because the moment that you have the know-how of the ultrasound vision, and the moment that you have the technology of the wireless probe, you may check it whenever you want, basically. So you check every time you have the doubt, maybe it's moved. That's the indication for doing immediately bedside the POCUS and check whether the catheter has moved.
Great, thank you, Mauro. Anna, do you want to?
And yeah, no, I was just thinking, you're mentioning the importance of knowing how to use that POCUS tool and being able to have it always in your pocket, essentially. And there's a question, of course, about how to learn to identify the tip position, so how to use POCUS for lines, and if there are any courses that you might want to suggest, or any other sources of training that you might want to suggest. That's an open question for both Mauro and Robin.
Yeah. Well, I tell you what we are doing in our country. We do specific courses, neonatal courses and pediatric courses, and we have been doing the last 5 years something like 35 or something, at least 30 neonatal courses in different hospitals and different neonatal intensive care unit. In Italy, there are 110 neonatal intensive care unit, more or less. So I think that we covered at least 1/3 of this neonatal intensive care unit. When we do, of course, the tip location, we do theory, practice on volunteers and on babies, and then we have the trainees doing themselves the maneuver. There is a very big bulk of literature, especially condensed in the big book that I told you, the manual of vascular access, the handbook of vascular access in neonates and children. There are many videos that you can download freely from our website, and also there is a framework for training, which is in the NeoFOCUS, which is very useful, because sometimes the critical point in the training is what is the vehicle of the content. And if you have everything already structured in a vehicle which is very clear, very schematic, like the NeoFOCUS, training is easier. This is our Italian experience to now.
Robin, do you want to add anything?
Yeah, I think Mauro and his and the Italians, they really do an amazing job. They're way ahead of most countries in Europe. The only thing I want to add is we are giving from NEVAT. We also provide some courses. It's gathering steam a little bit, and it's also within the special interest group of vascular access in the ESPR. But what I want to say is that there is no course that can actually reliably teach you completely how to put in an ultrasound guided central catheter, because you can learn part of it, but the whole process, I think it takes quite a bit of work. In my experience, but maybe Mauro is not. Maybe you should comment on that, because there are so many elements that you need to consider and you need to be aware of to do it safely. That with a course you can start with some basics, but you need an expert or someone who's good at it.
Yeah, I was referring. You're perfectly right. I was referring to the course on tip location. Tip location is something very easier because it's not invasive, it's not risky, something that you can actually teach. And even if you are not able, I mean, you can have babies in an intensive care unit who has an umbilical venous catheter. You come there with the trainees and you show how to visualize the catheter. The ultrasound, the puncture, guided puncture is another story. And we still, in this regard, the lesson is the lesson of the Wokova consensus of 10 years ago, which tells that every time you have to teach an ultrasound guided puncture, there are 4 different stages: the theory, the practice on simulator, the learning curve, proctor, the learning curve, and the autonomous unproctored learning curve. This is a complete another type of course, which needs, of course, hands-on, extensive tutoring. And I will say that to be very proficient in the puncture of the brachiocephalic by ultrasound, you must have a very good experience of a long practice on simulator and a long learning curve with the proctor. That's for sure. Tip location is another story. Tip location is something that you can be very confident after 10 or 1 dozen of personal procedures. Ultrasound guidance is much more demanding, of course.
That's fantastic. Okay, I think we have reached the end of the session for today, and I really want to thank you both, Mauro and Robin, for their contribution, because it's been a fantastic opportunity to go through the advances in neonatal access, but also I think most importantly, the idea of how to approach in a systematic way a topic that is so important and so relevant to all of us. I also want to thank Mahmoud, who has helped me co-moderate in this session. And I would like to thank all the 80 plus attendees that have joined us. You can all join us to send us a, you can all send us a feedback. I was typing that while talking. I will send us a feedback on our education NeoFOCUS-UK group following the link that I just shared. And I might just be able to share also a little slide with a QR code that you should be able to see that you can scan if you would like to send the feedback. So again, thank you so much, Robin and Mauro, for taking the time to go through such interesting topics with us. I hope we'll have the chance to collaborate again in the future and make sure that we all together provide best care to our patients.
Thank you, everyone.
Thank you.
Pleasure.
Thank you.
Thank you.
And thank you.
Bye-bye.
Goodbye.
Bye-bye.
Bye.
Thank you for watching. If you enjoyed this, please check out the other webinars on our channel.